And since Dr. Digvijay is unable to join us due to personal setbacks, I request Dr. Mahesh, my co-chair, to start his first talk, Visual Fields Essential Tool of Neuro-Ophthalmologist. Dr. Mahesh is a senior consultant and prolific teacher, heads the Aravind Eye Hospital Neuro-Ophthalmology Department.
Thank you, Dr. Ambiga. So good afternoon all, and thank you for attending this course. So the topic given to me is visual field testing, the importance of visual field testing in neuro-ophthalmology, and the time given is some 6 to 7 minutes. So I'll have to summarize the most important findings and most important points here. So visual fields is one of the most important visual sensory function, the other being visual acuity, color vision, and contrast sensitivity. So this figure is for the postgraduates. It's a hill of vision surrounded by a sea of blindness, and this turquoise hill of vision, I hope all the postgraduates remember this. And the objectives of this presentation is to highlight the various field testing strategies in neuro-ophthalmic diseases. And to some extent, I'll be covering the visual field effects in neuro-ophthalmic diseases. So the objectives, the value of fields in neuro-ophthalmology lies in localizing the lesion, lateralizing the lesion to some extent if possible, to the right or left side, purely based on the visual fields, as well as to some extent, unlike glaucoma, where every visual field is done for a quantitation and seeing for progression or regression by quantifying with numbers, to a large extent in neuro-ophthalmology, we just do a quality examination rather than quantification. But in certain instances, like following up a case of a pseudotumor cerebri, idiopathic intracranial hypertension with papilledema, we need to track the progression of the visual fields, whether it's regressing or getting better. Similarly, an optic neuropathy secondary to a thyroid eye disease, or a tumor progression or regression. For example, a pituitary adenoma being followed up with a medical treatment, the endocrinologist might want to know whether the tumor is regressing and whether the optic chiasm is getting released by the tumor. And here quantification is important in neuro-ophthalmology. Broadly, the types of visual field testings are confrontation field testing, Amsler grid, kinetic and static perimetry, and confrontation is not to be underestimated, and finger counting to the right and left of fixation, a red target testing with specific red color objects, because certain optic nerve functions are very sensitive for red targets. And together with all these testings, confrontation will pick up more than 75% of neurological field effects. So its importance cannot be overemphasized. It's extremely important to do a confrontation field testing. Next is Amsler grid. So the traditional understanding is an Amsler grid is something to do with the macula, something to do with the central fixation points. But we need to remember that certain optic nerve dysfunctions like a toxic optic neuropathy or an optic neuritis can impinge on the papillomacular bundle, which deals with the central vision. And so in specific instances, we need to do the Amsler grid also in optic nerve dysfunctions to look for a central vision loss. Kinetic perimetry, the Goldman has largely become out of vogue now for want of the machines availability and the maintenance of it, and hardly very few institutes still maintain it. And if it is available, it is of very much value, but the downside is that it is a time consuming test and requires a very trained perimetrist to undertake this test, and because of these disadvantages it has fallen out of vogue. And a simple Jerem screen or a tangent screen will still holds good in some institutes. Central 30 degrees is a good testing strategy in Jerem screen. In automated perimetry, the pattern than light sensitivity, the pattern of visual field effects is more important, and it is denoted by the grayscale. Even though the glaucomatologists may not like the grayscale, in neuro-ophthalmology to a large extent the grayscale is good enough to test these field tests to these neurological fields like this one. We have the grayscale, which grossly gives the field effect of a right homonymous inferior quadrant anopia. And we need to place a neurological field side by side. Unlike glaucoma fields which are seen individually, neurological fields need to be placed side by side because we are dealing with a bilateral problem because of the chiasm and the retrochiasmal field defects. Place the right on the right side and the left on the left side as the patient sees it. As the patient sees it, and that's the right way to hold these field charts. And apart from that, we do most instances we do a central 30-2 because we need to see the peripheral junctional scotomas. A 30-2 is preferred for most neurological field defects. And in some instances where the patient may find it difficult to cooperate, a wheelchair patient, a neurological hemiplegic patient may not be able to sit for the visual field testing for a prolonged duration, then we can perhaps do a supra-threshold full field 120-point screening test can also be employed, and to a large extent this also will give the neurological field defects. You can see here a bilateral bitemporal heminopic field defect here picked up only by the 120 supra-threshold field testing. So the other field defects which we see neurological field defects are the homonymous field defects, and if you see an incongruous field defect like this, in this instance a left homonymous incongruous field defects. For the postgraduates, if anybody is here, remember that an incongruous defect is indicative of an optic tract lesion. Optic tract lesion, incongruous, and the more the posterior the lesions are, it becomes more congruous. But there is a caveat here: if this field defect becomes complete, meaning becomes complete homonymous heminopia, then it is non-localizing. We cannot say that it is not arising from the optic tract. It could still be arising in the optic tract. To begin with, it could have been incongruous, and once it has become complete, it's difficult to say whether it's in the optic tract or in the radiation. So if it is an incomplete lesion, we can to a large extent say that whether it's congruous or incongruous. So the other field defects are a temporal lobe lesion here, such as this abscess pressing on the Mayer's lobe, producing what is called as a congruous superior homonymous quadrant anopia. For PGs who are unable to remember the temporal lobe is below, so it will produce a superior quadrant anopia or a pie in the sky. And similarly, for the optic radiation in the parietal lesions, such as this one, which is a meningioma in the parietal lobe, you may have a pie in the floor appearance, pie in the four field defects, which is an inferior quadrant anopia, because here the fibers are superior in the parietal lobe and may correspondingly present a inferior field defect. I'm just summarizing last few slides. Remember, the occipital lobe lesions always pair the macula, which is the central 10 degrees. You all know the reason: bilateral supply, posterior cerebral artery, middle cerebral artery, as well as a large macular representation. So a wedge-shaped defect, and a bilateral here, it's a bilateral occipital lobe lesion. There is a small field defect called as a temporal crescent. If there is an infarct in the anterior part of the occipital cortex, where this temporal field does not have a pair. Remember that the temporal field is larger than the nasal field. So a small amount of a temporal field cannot have a pair on the corresponding nasal side, and this is called as a temporal crescent. And this is the only field defect retrochiasmally which is unilateral. And this happens when this part, anterior part of the occipital lobe is involved. So there is a place for 10-2 also in the neurological field defects. I told you these neurological field defects occasionally can cause central field defects like toxic optic neuropathies like ethambutol, chloroquine, LHON, Leber's, or an optic neuritis. Central or centrocecal scotoma can be specifically picked up by 10-2 central field defects. So in summary, we need to do confrontation fields, Amsler grid. A Jerem screen may be employed for central scotomas, homonymous field defects. A Goldman is ideal if it is available. And in Humphrey fields, 10-2 for central defects, 25-2 for most homonymous bitemporal field defects or homonymous field defects. And 120 full field tests can be done in a supra-threshold manner for quick screening tests in difficult patients who are unable to cooperate. Thank you for your attention.
Thank you, Dr. Mahesh. An excellent overview of fields, which actually form one of the most essential investigations in neuro-ophthalmology, probably just after vision and pupils. So these trio actually give us a lot of information and are a must for every patient of neuro-ophthalmology. We'll go on to the next presentation, which is by Dr. Ambika, who will be talking to us about approach to a patient with vision loss and normal fundus. So very often in neuro-ophthalmology, we'll end up having these group of patients present to us who have a subnormal vision but a normal fundus. So Dr. Ambika will be telling us how to go about approaching and managing them.
Thank you, team, for having me on board. And I'm going to talk on approach to a patient with normal fundus and yet a vision loss, which is unexplained. Can you advance the slide? It's not. Yep. Okay, so unexplained vision loss is one of the most important things which you have to be very concerned in practicing day-to-day clinical practice, where you have to differentiate an optic neuropathy versus the retinopathy versus the other comprehensive ophthalmic causes. So because of the atypical presentations, you definitely need a comprehensive evaluation and to a certain extent a clinical expertise to decode these conditions. And we do have help from electrophysiological studies, neuroimaging do play a vital role in pinning down them. But you have to be careful because they have a lot of medico-legal pitfalls because the functional visual loss lingers in this group of disorders only. So we are very happy as neuro-ophthalmologists see when we have a patient who is having a drop in vision coming with various disc edemas like this, because we know very well that every disc edema has a particular cause behind that as a cause for the vision loss. And similarly, even there are so many shades of pale disc, starting from chalk white to gray white to say whatnot. And these can be also decoded as the various causes for the vision loss. But what if the fundus is normal? What if you're not having any positive clinical features? Do not forget to do these basic steps of optic nerve function assessment, starting from vision, color vision, pupil to a detailed anterior and posterior segment evaluation. And all these ancillary ophthalmic evaluations do pitch in now and then to find out what is the cause behind this. But do not forget to do a basic pupillary examination if you have a uniocular vision drop, which is not a before the chiasm, you will have a pupillary dysfunction. Retrochiasmal dysfunctions yet have a normal pupillary function. And if it is going to be a binocular optic nerve dysfunction, you may have a sluggishly reacting pupil unless you don't expect a relative afferent effect in that. So this is not an uncommon scenario which we all face in our day-to-day examination, where a 65+ male is brought by the attender with a complaint of sudden vision loss. So you see bilaterally normal reacting pupils, dense cataract, and a normal fundus. VEP is having a mild delay in latency, but still cataract is not the only cause for the drop in vision. So the key point is the history of sudden vision loss. The attendant is saying that the patient started groping from today morning. He was apparently fine since yesterday. Cataract cannot crop on overnight. Okay, so that one history is very important. So give importance to the history taking with the onset of the vision loss. That's what is going to guide you here. So the next point is you go ahead, go get an MRI brain and orbit, where the patient had a bilateral PCA infarct. He already had one side infarct and the other side started a acute infarct. That's the reason why his pupils were briskly reacting, normal, dense cataract, but yet he had a cortical visual impairment, and he is not an ideal candidate for you to go for a cataract surgery. And there are some other cases which I would like to share. This is a 17-year-old girl who was brought to us as a monocular, as a bilateral vision drop, where the father was saying that she's malingering, and as per the local doctor, because all her evaluations was normal. So what is one investigation which can be useful at this level, where bilateral pupils are sluggish with the hand movements close face? Yes, VEP. VEP is going to give you the clue that there is delayed latency and amplitude, and both the eye fundus are yet looking normal. So you're dealing with a bilateral optic pathway dysfunction, and that's a retrobulbar neuritis. Do not brand this as a malingerer. We are going to miss something huge. So this patient had a normal MRI brain in orbit. We went ahead, treated with IV steroids, and a visual gradually improved over a course of 1 month, but still persisted central visual field defects. So in down the line, 4 years later, she came with a slightly better vision, but still she came up with something history which is really startling to us, where she had sensation losses, unable to hold objects with a poor bladder control, and persisting visual field defects even at that time. And that's the MRI when you see. So when you get such history, be very careful, repeat a neuroimaging, look for demyelinating signals, and this patient had even cervical cord signals, and she was negative for the seromarkers, but she was screened for oligoclonal bands, which was also absent, but yet she was having features of MS, so she was put on interferon, which is an immunomodulatory agent. So that began as an unexplained vision loss in an ophthalmic clinic. So this is another female with a monocular vision loss similarly. Here, she is complaining of a monocular vision loss, yet there is no relative afferent pupillary defect. So the color vision, VEP, and fundus were also normal when she came to us, again brought as a malingerer. So this visual field helped us to say that she's not malingering, and she's definitely having some problem which is probably disturbing her in the left eye, and that's what you see is an enlarged blind spot. And she had a normal FFA apart from a mild disc staining in the late phases, and also OCT had a normal RNFL. So probably she could have been a candidate who had this white dots which resolved, and when the time she presented, only the idiopathic blind spot was still enlarged. Here there is no role of steroids. All you have to do is watch her over a period of time, repeat the visual fields, and that's her visual fields after 10 months. This is a 74-year-old man who was brought by a pediatrician, her father, who had uneventful cataract surgery, 6/6 vision, but he was very unhappy even after the cataract surgery. And this is the fundus. So you see, apart from a mild RP stippling scattered throughout this montage photo, you see a normal vasculature and the disc is fine. And now you see the visual field is obviously constricted and severe, almost like a RP-like picture he is having. So here ERG helped us in finding out there's a non-recorded single flash waveforms. It was both in the photopic and scotopic stages. His MRI was normal, VEP revealed delayed latency, and then it turned out to be on our oncology screening that he had a CA lung, and what we saw was a cancer-associated retinopathy which erupted earlier than what we made the diagnosis of the chest lesion. So this is a 25-year-old male where he was referred to us as an optic neuritis following a fever. So he had a 6/12 vision. So maybe I will wind up and go. This guy had a bilateral central scotomas, but here it was a toxic maculopathy secondary to chloroquine rather than the optic neuritis. So to conclude, in an unexplained vision loss, the most important thing is history taking. And optic neuropathy can be picked by the tempo of the vision loss. If it is an acute painful loss, it is mostly an optic neuritis. If it is painless, it could be an ischemic cause. And if you have an overlay of maculopathy as a cause, you will have macular symptoms like metamorphopsias and photopsias. Amsler testing can be useful when you have a central visual field defects. And electrophysiology, neuroimaging, and visual fields all have their respective roles in finding the cause for the unexplained vision loss, but none other than a detailed history taking is going to help you to decode this type of causes. So always talk to your patients before ordering any investigations. Thank you.
Thank you, Dr. Ambika. We'll probably keep the discussion and questions to the end. We'll next go on to the presentation by Dr. Ankur Sinha, who unfortunately could not be here with us, but he sent his recorded presentation. Can we play the presentation by Dr. Ankur, please?
Good afternoon to each and everyone. At the outset, I would like to thank Dr. Digvijay and AIO's office bearers for giving me this opportunity. I'll be talking on basic neuro-ophthalm examination. Now, neuro-ophthalm clinical evaluation starts with history taking, ocular examination, which includes the visual acuity, palpation, pupil, and the fundus examination, systemic examination, and investigations which could be ocular or systemic. Now, vision loss is a very important symptom of neuro-ophthalmic disorders. The way it occurs, it can point towards the causes. So if it is occurring within seconds and minutes, probably we are looking at a vascular or a traumatic cause. If it is occurring within minutes, hours, and days, then we are looking at an inflammatory or a cause because of elevated intraocular pressure. If it is occurring very slowly over a period of hours, days, and weeks, then we have a disease which is either a space-occupying lesion or a chronic or a degenerative disorder. Now, history taking starts with a duration, that is whether it is a recent onset or long-standing, whether the symptoms are improving or worsening, are there any associated complaints of headache, vomiting, seizures, history of any focal neurological symptoms or comorbid illness, family history of hereditary neuropathies or autoimmune conditions, treatment history of medications, and previous investigations. Now, visual acuity is a very important baseline parameter. Even if the patient has lost his vision at the time of presentation, but we can still ask that how the vision loss has occurred and when it has occurred. Snellen's acuity is more than adequate, but we should allow the patient to respond because sometimes the neuro-ophthalmology patients may take more time to respond than normal patients. Check for the best corrected visual acuity with pinhole. Also check the near visual acuity because in some cases, the near visual acuity is knocked off. Now, confrontation vision fields can be done at the bedside, and they are helpful in detecting pituitary tumors, ischemic neuropathies, and papillodemas. This is also a good test to make the patient realize that what he is missing and what are the potential dangers of the neuro-ophthalmology disorders we are thinking of. Now, this is a photograph which is showing you how the confrontation visual field is to be done. Now, pupil are a very important part of examination. So, assess the pupil size, test the pupillary reactions, check for the near response, pupillary dilatation, and test for the RAPD. Now, measurement of pupil can be done with the help of pupillary gazes or handheld pupillary cameras. We also have infrared pupillometers where we can kind of document the pupil size very accurately. Also assess the pupil size in darkness, light, and near. A difference of more than 0.4 millimeters can be termed as anisocoria. Now, always check the reaction to light. For this, we have to dim the surroundings. Ask the patient to look at distance. There should not be an attempt to look for near as it can cause meiosis. And note the pupillary escape, that is once it dilates after constriction. Also note the latency of speed of constriction and dilatation, and also check the consensual light reflex in the other eye. Check for the near response, that is the near triad of meiosis, convergence, and accommodation. Use the dim light and use an accommodative target for same. Check the pupillary dilatation. Also check the reflex dilatation to sudden noise or painful stimulus. Dilatation lag can be seen with dilatation lag with anisocoria can be seen in patients of Horner syndrome, and it can sometimes be normal. Check for light near dissociation where light reaction is almost always impaired. RAPD can be checked with either a Marcus gun or a gun phenomenon or a swinging flashlight test. We can also use neurodensity filters to quantify the RAPD as these density filters aggravates the mild RAPD. If both the pupils are not reacting properly, then we can check for the H light pupil cycle test. Here, a small horizontal beam of light is shown to the pupil. So as the pupil constricts, the light is cut off, the pupil dilates again. And we kind of count the number of constrictions and dilatations in 1 minute. And then we divide it by 60 to find out the time required for one pupil cycle. So if it is more than 954 milliseconds, it is not normal. Physiologic test can be done with diluted pilocarpine to check for supersensitivity, normal pilocarpine for pharmacological blockade, cocaine or apaclonidine for sympathetic defect, and hydroxyamphetamine or phenylephrine for postganglionic sympathetic defects. Now, this is the case of 12-year-old boy with drooping of lid for last 2 years. We can see there's a right mild ptosis, and right pupil is smaller than the left. So the patient is diagnosed as AD's pupil, subjected to a MRI where we can see there's a large paraspinal mass in the apical region close to the trachea. So patient undergoes CTVS surgery, and histopath shows benign nerve sheath schwannoma with cystic changes. This is another case, a 48-year-old male, where we can see the left eye pupil is larger as compared to right eye in the presentation. And when we do the direct light test, we can see that the right eye pupil constricts, but the left eye pupil doesn't constrict so well. So we can think probably that the left eye is not, left pupil is not working properly, and the left pupil is abnormal. We also check the consensual right reflex. So right eye, when we shine, is constricting well when we shine the bright light on the left side. Similarly, when we shine the bright light to the right eye, the left eye doesn't constrict. So probably there is an efferent defect in the left eye. Also, when we check on the slit lamp, the right eye has a concentric constriction, but the left eye has vermiform-like constrictions. So, as we can see now, And this is at presentation, and this is after 5 minutes of reading. So sustained near work did cause some amount of pupillary constriction in the left eye. So he's diagnosed as AD's pupil, and is prescribed asymmetric AD and photochromatic glass. Systemic examination includes noting down the vitals, the pulse and the blood pressure, the CVS examination, respiratory examination, abdominal, and examination of central nervous system. Now investigations. So investigations could be ocular, where we check for color vision, contrast sensitivity, visual fields either by static or kinetic, and then we have visual evoked responses, whether flash or pattern. Color vision is an important test. In optic nerve disorders, we have red-green color blindness, while macular disorders, we have blue-yellow. And optic neuritis, we have red desaturation test, where we can show a bright red color with the either eye. And formal testing should be done with the help of Ischiaras or any other test. Contrast sensitivity should be done. It is a very sensitive test. It gets affected before the visual acuity, and it may not completely recover. And we have almost all electronic visual charts where we have these Pelly-Robson's kind of chart which is available. Now, systemic investigations are a battery of investigations. They have to be selected depending upon the profile and the symptoms of the patient so that they are best fit. So in the end, I would just say a methodical exam and a good workup is a must to arrive at good diagnosis. Thank you. A very good afternoon to each and everybody.
Thank you, Dr. Ankur. Can we now... So, thank you, Dr. Ankur, for sending us. Next, we are going to have Dr. Rashmin, who will be talking about the use of OCT as an effective tool in neuro-ophthalmology. So, OCT is increasingly having a role in diagnosing, managing, following up patients of various neuro-ophthalmological disorders, particularly including neurological, but particularly optic neuritis, ischemic neuropathies. So we have Dr. Rashmin to tell us the emerging role of the OCT.
Thank you, Rohit, and I'd like to thank Digvijay, Rohit, and the entire team for inviting me for this lovely symposium. OCT has, it appears that OCT is gaining ground in neuro-ophthalmology, and day before yesterday we had a free paper session. We had 10 free papers, out of that 6 or 7 indirectly were talking about OCT. So we know that all across India there is a lot of excitement about what OCT can do in a neuro-ophthalmic practice. Now, what do we look at if you have an OCT picture? And this is going to be a very basic talk for us to implement it in our practice. This is a typical OCT chart, and what you're looking at is RNFL thickness. This is the right eye, this is the left eye. The green one is normal. If it's white, you know that probably there is a little dyschedema there. If it's red or yellow, you know that there is a loss of average RNFL. So one of the important uses of OCT is to look at average RNFL. That gives you the structural health of axons. Now, what is gaining ground now? This is RNFL. What is gaining ground is also looking at ganglion cell, GCC IPL complex or GCC, depending upon what machine you use, and that gives you the health of neurons. So there are two things you're looking at: axons, which the information you get by average RNFL. If you're looking at GCC map, you are getting the information about neurons. Why these two different things? RNFL generally gets affected, or whatever changes which are occurring in the eye, it gets reflected in RNFL earlier. However, it does not exactly correlate with what's going on clinically, versus GCC, which takes around 2 weeks for it to get affected by the pathology. But the GCC health gets reflected into clinical picture, and that's the reason why GCC is gaining more ground about looking at it in neuro-ophthalmology. Now, where can it be used? So we spoke about RNFL, we spoke about GCC. Where can it be used? It can be used for prognostication, monitoring the progression, and diagnosis. I don't think OCT has attained the maturity for it to be used for complete diagnosis, but I know that progression or prognosis or progression, it has a good role to play. Important thing, and this is where I think a lot of us, I have started using OCT as a primary tool, prognostication. There was a paper long ago by Dr. Savino and group where they looked at average RNFL thickness in patients who were undergoing a treatment for chiasmal tumors. And they were able to predict that if average RNFL was less than 60, those patients carried a poor visual prognosis after removal of tumor. Now, this is a very important application. Patient would ask you, because those patients would have come to you, chiasmal compression, will I regain my vision? Will I regain my visual field? OCT probably will be able to tell you, if you look at average RNFL, which is lesser than 60 in that paper, you know that maybe removal of tumor may not have a major impact on restoration of visual acuity or visual field, versus somebody who carries a good RNFL pre-op probably is more likely to regain vision or visual field test. So that was average RNFL. The similar study was done on ganglion cell as well, and it was much more predictive. So if somebody who has pre-op thinning of ganglion cell complex, he's much less likely to regain vision after chiasmal, after the brain tumor surgery. So prognostication is an important indication for these patients, and OCT is a tool. Now, second important application is a patient like this who has a papilledema. So what is the role of OCT in papilledema, or presumed role? There is a lot of talk about OCT being helpful in differentiating between a true disc edema and a pseudo-disc edema. So to differentiation between papilledema and optic nerve swelling, because of cases like this, drusen, it is believed that probably OCT would have a role to play, though again, there is a lot of discussion about validity of this finding, but that's the other application of OCT, differentiation between true disc edema and a pseudo-disc edema. And one of the feature is this, you see the internal contour of ONH, where it will be a smooth contour in a true disc edema versus a lumpy, bumpy contour in somebody who has optic nerve head drusen. The third application, somebody who comes to you for routine ophthalmic evaluation, visual acuity is fine, but you find a disc which appears a little suspicious, as you see here in the patient. The right eye disc looks a little pale. So is it really pale? Do you need to chase? Probably OCT will give you a clue. If the nerve which appears pale has a significant loss of retinal nerve fiber, you know that maybe that patient has, that pallor is significant. The other application of OCT would be other neuropathies, optic neuritis. We discussed about the role of OCT in optic neuritis in the morning session. It is believed that multiple sclerosis, even if the patient did not have any clinically apparent optic neuritis attack, he may still exhibit loss of RNFL in the eye. There is also belief that maybe OCT will point whether this optic neuritis is because of multiple sclerosis or NMO, because which part. Let's say it's believed that NMO, the thinning is more superior and inferior, versus MS where the thinning is more temporal, though I still believe that these are not really mature enough to say that you can base your diagnosis. They might be indicators. OCT also can show RNFL thinning in neurodegenerative disorders like Alzheimer's and Parkinsonism. So in a nutshell, OCT is gaining grounds. I personally use it for prognostication. It can be used for following up the patient, especially with papilledema. The other uses, I think, will require some more knowledge before we can implement it as a gold standard in clinical practice. Thank you so much.
Thank you, Dr. Rashmi, for that excellent coverage of OCT. Next, I would like to invite Dr. Digvijay Singh is not able to come due to unavoidable reasons, healthy reasons. So we'll play his video on approach to a patient with pale or swollen discs, a recorded video.
आता नहीं अच्छा फुल स्क्रीन ये तो आ ही रहा है, इसको ऊपर से प्ले कर दें क्या?
Approach to a patient with pale or swollen discs. taking a history of diminution of vision. Was it sudden or gradual? Was it transient or is it permanent? Are there any associations such as double vision, pain or ocular movements, headaches, any other focal neurological deficits? On examination, look for the ocular movements, any dysmotility, any paresis, any ptosis. Look at the pupillary responses, particularly the RAPD. In the fundus, look at the disc features, and depending on the pathology, do the color vision. It's very important, the contrast sensitivity. So if the visual functions seem to be affected out of proportion to the visual acuity, that may sometimes be seen in optic neuritis. Do a confrontation visual field to get a basic idea of the visual field defect. If what you see in the fundus is a pale disc, try to classify it. Is it a primary optic atrophy or a secondary optic atrophy based on its features? If what you observe in the fundus is a swollen disc, then look, is it unilateral or bilateral? Is it hyperemic or pallid? Here are some examples of disc edema. The investigations include ocular investigations such as the visual fields, where you want to try and find what type of field defect is it. Is it a central, centrocecal, altitudinal, constriction, hemianopic, what kind of field loss? You can do the OCT to look for the RNFL thickening or loss. A VEP can help you know whether the visual function there is a delay in the P100 latency or not, or there's a decreased amplitude. And neuroimaging such as a CT or MRI is often needed. Optic neuropathy would fit into one of these various etiologies. Let us look at a few cases. This is a young male who has had loss of vision in one eye after a road traffic accident. You can see the primary optic atrophy in the left eye. The imaging shows an orbital fracture near the optic canal. This is a 36-year-old female with gradual loss of vision in both the eyes. You can see that there is a temporal pallor appearing in both the optic discs. The differential diagnosis could be either a bilateral retrobulbar neuritis, a toxic optic neuropathy, some kind of a compressive optic neuropathy. On investigation, the visual fields show a bitemporal hemianopia. That immediately becomes an indication for imaging. Imaging shows a large pituitary macroadenoma that is compressing on the chiasma, and the plan is a neurosurgical intervention. So here is a primary optic atrophy due to a compressive optic neuropathy. A 24-year-old male patient with vision loss in both the eyes is showing a bilateral temporal pallor on his optic nerves. There is a central or centrocecal scotoma on the visual fields. This could either be a toxic optic neuropathy, but one always has to keep the Leber's hereditary optic neuropathy in mind as well. A 50-year-old male patient with occasional headaches having a gradual progressive loss of vision in the left eye presented with minimal proptosis. All visual function in the right eye were normal. You can notice how there is a secondary optic atrophy in the left eye optic disc. The differential diagnosis could be optic neuritis, an inflammatory optic neuropathy, a compressive optic neuropathy. The investigation of choice here is a neuroimaging. Neuroimaging reveals a sphenoid wing meningioma, which would require a neurosurgical intervention. So there was a compressive optic neuropathy going on to a secondary optic atrophy. Here is a 32-year-old female with sudden loss of vision in the left eye. You can notice that there is slightly blurred disc margins, so there is a unilateral disc edema, which is hyperemic, very suggestive of papillitis. So the differential diagnosis, the topmost would be an optic neuritis. And here is another young female who's overweight and has history of headaches on and off, and presenting with a normal visual acuity, but very swollen discs. You can see peripapillary hemorrhages, very, very swollen bilateral disc edema. The MRI is within normal limits. So this is likely to be idiopathic intracranial hypertension. And you want to investigate by doing an opening pressure by a lumbar puncture, and treatment would include medical treatment using acetazolamide or sometimes surgical optic nerve sheath fenestration or VP shunts. This is the fundus image of an elderly, hypertensive female who's noticed vision loss on waking up the right eye. There is a right eye RAPD. You can see there is a segmental disc edema in the right eye. The left disc is showing a very small cup disc ratio. This is highly suggestive of NAION. In the next slide, you will be able to see the OCT images and the fields showing disc edema and a highly constricted visual field. Management of NAION involves control of the systemic factor, which is blood pressure in this case, and over time you can see that there is some improvement in visual acuity. So the idea is to approach each case in a systematic manner, know the typical presentations, place the patient in one of the few buckets, such as is it a primary optic atrophy, a secondary optic atrophy, is it unilateral disc edema, bilateral disc edema, and then do targeted investigations for the same.
Thank you. Thank you. Next, I would like to request Dr. Rohit Saxena to give his talk on understanding basic neuroradiology imaging. We'll take questions in the end if we have time, so we'll finish off with the presentations. We are running out of time.
So thank you, Digvijay, of course, for including us in his IC, and AIOS for giving us the opportunity to be here. Neuroimaging forms I would say, sheet anchor for all neuro-ophthalmological conditions, and therefore just a basic understanding would help. We'll try and look through all this huge amount of gamut of investigations, which are probably increasing at a very rapid pace. Where would CT be useful? CT, we know, with the increasing use of MRI, is taken a back seat, but we know that there are significant advantages also of CT. Of course, the radiation exposure is a problem, but it takes a very less time, very quick, low expensive. So, and of course, where MRIs are contraindicated, where there are implants. So CT is better than MRI in subarachnoid hemorrhages. If you're suspecting a hemorrhage, patient comes with issues and you suspect there's an intracranial bleed, an urgent CT would be the ideal thing to do. Calcification, if you're looking at calcification lesions, you can see this MRI is telling us something what's going on here, but the moment you know calcification there, you're looking at tuberculomas. You are not sure clearly what this is, suspicious but not clear. So this was a case of a patient with the wrong eye. He came to us, 24-year-old male, history of trauma on the right forehead, followed by a sudden loss of vision in the left eye. Now that was surprising. I even asked the resident, are you sure that's the correct vision? And he was like, no, probably right, long, left, right, left, right. So anyway, of course, the pupil gave it away. And we knew that there is right traumatic mydriasis, left divergent squint. So the injury was appropriately in the right forehead, but the vision loss was in the left eye. Now, how is this happening, and how are we calling it a traumatic optic neuropathy? So here you can see evidence on the VEP also. We make sure we know that on the left eye there is hardly any waveform, so you know left eye is injured. So here the CT comes in to help. So you can trace the fracture lines. So a 3D reconstruction of the NCCT showed the fracture line running obliquely from the right to the left on the floor of the cranial fossa involving the left optic nerve. So the traumatic optic neuropathy on the left side, and we are able to equally trace it. So that case of the wrong eye was actually solved. Another case of optic atrophy, 13-year-old male, gradual loss of vision, progressively over a few years. Young male, you can see pale discs. Now, obviously, there's optic atrophy. MRI, your differentials would be compressive, hereditary, toxic, nutritional, whole gamut. First step, of course, compressive. Got the MRI. MRI is essentially normal. So, reported normal, what our basic understanding was normal. We started discussing with the radiologist. Everything looked okay, but just on one film, they just said that these kind of nerves, kind of are tapering in. So, can we do a CT and go ahead and have a look? And this was the CT. So you look at these bones. So this is osteopetrosis-induced optic canal narrowing. Not a very common feature, but you can have bony problems and the CT helps there. So a CT would have role in bony lesions, hemorrhages. A quick, if you want to, a low-cost evaluation to rule out a gross space-occupying lesion, calcification, cysticercosis. So cysticercosis, of course, you can get it on the ultrasound, also on the orbit, but of course, intracranial cysticercosis. An MRI is better than a CT if you're looking at brainstem lesions. Small brainstem lesions will get missed on a CT. Meningeal dural inflammations. Meningeal inflammations will nicely pick up on a contrast-enhanced MR. Cavernous sinus lesions, very difficult on a CT. Anywhere there is a bone around or close, you're going to have artifacts and you're not going to be able to make. So when you're looking at the vault, CT, when you're looking at things inside, MR. And aneurysm. So a CT will obviously miss an aneurysm unless it has calcified walls or something. So aneurysms. So a 26-year-old female presented with sudden loss of vision in one eye, left eye vision affected, right eye normal, left RAPD, left papillitis. Do we image, and what would we want to image for? So the importance to remember now is that if you think optic neuritis, every patient must be imaged. It's almost a rule now. You learn so much by an MRI that it's really now mandatory to image all patients whom you suspect to be optic neuritis. So flare, it's important to do a flare. So a T2 MRI brain and orbits with contrast. So you are able to make out these lesions on the brain will highly suggestive of a development of MS, and you may require to do give disease modifying agents. So these are important things. So MRI role, the ONTT gave us an idea that MRIs can help to prognosticate the likelihood of patients who will develop. So a T2 weighted flare with a contrast. So this is important. Like I said, all patients, but mandatory if there is any doubt, cost things, recurrent, keen to know about prognosis, history of other neurological involvement, atypical, very, very important, extremely important, because NMO-MOG is increasingly a component that is presenting, and you are able to get a good idea or at least a suggestion of possible NMO in patients looking at the MRI, and of course in children. This was a patient of disc edema, bilateral disc edema, swollen discs, almost secondary atrophy. We wanted to know whether we want to go in for ONSF or not. Her vision was significantly affected. Of course, Jyoti from Narayan Netralaya prefers to do the ultrasounds, but somehow in our hands we've not found so much great result. So an MRI, you can see this huge cuff of fluid. Of course, the CSF tab will give us the severity of the raised intracranial pressure, but this also gives us an idea how much space I have when I want to go in for ONSF. The VERs were moderately affected, but you can see after surgery ONSF, it improved to 6/18, so definitely a significant improvement. Another disc edema, obese patient, you can see the edema, which is modest. You need to rule out a space-occupying lesion. That's the first step. So if you suspect a space-occupying lesion, you urgently want to know, you could go ahead with a CT, but invariably these patients require an MRI. So therefore an MRI is important. You're thinking of papilledema, and MRV may also be helpful. A unilateral pale disc, NAION was discussed, altitudinal field effects. Will the patient require imaging? Up till now, I would have said no, but recently a lot of little older patients are presenting with NMO-related problems. So earlier it was clear, above 40, 45, NAION, I don't need to worry about optic neuritis. Very unlikely an MS will present at 45, 50 as the first episode of involving optic nerve. But we are seeing the first onset of NMO in a little older patient. So probably, although of course diffusion-weighted imaging is still on the, being explored, but maybe over time it will help us to differentiate. Motility defects, particularly third nerve, pupillary involving, you can see moment third nerve, check pupil. Complete third nerve, check pupil, no pupil, don't worry so much. Partial, must still worry because it could be evolving, and imaging becomes extremely important in these cases, an MRI with an MR angiography to look for aneurysms. And finally, a gaze palsy. If you have a gaze palsy, an MRI helps. What I wanted to highlight here, a normal CT done outside, presumed nothing, so we didn't know what to, but looking at his motility, we knew it was a gaze palsy. So MRI, look at the brainstem. So the CT can miss brainstem lesions because they may just screen the upper part and get away with it. Started on ATT, you can see fully recovered. So MRI was the investigation of choice. CT can miss diagnosis in the midbrain, and of course, you need to localize what before what you want to do, you need to know where you are looking for and what do you think is there. Then you'll be able to decide whether a CT will help, an MRI will help, or you need to go on beyond this. So thank you for listening. Just want to invite you for the Indian Neuro-Ophthalmology Society on 26th, 27th of November at AIIMS New Delhi, and we hope to see you there for further discussions. Thank you very much.
Quick questions, anyone?
Yeah, we take questions and we'll wrap it.
Any questions? You want to summarize? Final.
So if there are no further questions, we thank you for your kind attention and we give the hall for the next session.